Welcome to today's Explainer. We're tackling a medical coding topic today that is honestly just as complex as it is fascinating. We're looking at the nitty-gritty of continuing pregnancies after a fetal reduction. Specifically, we're going to master the ICD-10-CM 031.3 subcategory. So if you've ever stared at an obstetric chart and just felt kind of overwhelmed by the sheer amount of maternal history, well, you are exactly in the right place. We're going to break this all down step by step so you can code these cases with total confidence. So, let's kick things off with a bit of a clinical riddle. How exactly do you code a single delivery that originally started as a multiple gestation? It's tricky, right? You've got a patient who delivers one healthy baby, but her medical record tells this much longer, much more complicated story of a twin or triplet pregnancy from earlier on. Capturing that entire history accurately, that's our goal for today. Think of the rules we're about to go over like a blueprint. We're going to build the structure of this code from the ground up.
Here is our roadmap for today. First, tracking high-risk pregnancies. Second, the O31.3 code family. Third, mastering the 7th character. Fourth, a second trimester case study. And fifth, a full-term case study.
Section 1. Tracking high-risk pregnancies. The clinical why behind the code.
Okay, so before we get totally lost in the numbers and letters, we really need to understand why capturing this history even matters. There's a massive contrast we have to make between our main focus today, O31.3 for elective fetal reduction, and codes O31.1 and O31.2, which are for spontaneous or involuntary fetal loss. As medical coders, we have to be incredibly precise here, because the clinical implications, the psychological impact on the mother, the medical follow-up, all of that is entirely different for an elective reduction versus an involuntary loss. Nailing this difference down is absolute step 1.
And here is the crucial takeaway. These pregnancies are always considered high risk, period, even if they've been successfully reduced to a single fetus. When that patient eventually rolls into the delivery room to deliver her one newborn, the clinical team needs that O31.3 code to immediately flag that, hey, this case was originally a multiple gestation. The documentation absolutely must reflect that origin story. It's really about ensuring the highest standard of care for the patient.
Section 2. The O31.3 code family. Mapping the trimesters.
So, if our coding process is a blueprint, you can think of the O31.3 base category as the foundation, and these subcategories are like the different floors of the building. Notice how that 6th character just neatly maps straight to the trimester. A 0 means unspecified, a 1 is the first trimester, 2 is second, and 3 is the third trimester. It really creates this beautifully clean, logical system. You just find out the timing of the encounter, match it to the right 6-digit, and boom, you've accurately placed the patient on the correct floor of our clinical blueprint.
Section 3. Mastering the 7th character. Pinpointing the specific fetus.
All right, this 7th character, this is where it gets super granular, and honestly, it's what often trips up even really experienced coders. It's a required final digit in the O31 category, and we use it to identify the specific fetus, like fetus 1 or fetus A. Going back to our blueprint metaphor, if the 6th character was the floor of the building, this 7th character is the specific room number. When multiple fetuses are involved, we have to know exactly which one we're talking about.
Let's quickly walk through these rules because they are set in stone. You use character 0 for single gestations or if the specific fetus in a multiple gestation is unspecified. Then you use characters 1 through 9 to identify the precise fetus in a multiple gestation. But, and this is a huge but, pay close attention to the mandatory rule. If you use a 7th character of 1 through 9, you must also assign a category O30 code to indicate the multiple gestation. They're basically a package deal. You can't have one without the other.
Now, what's truly fascinating is the clinical reality behind all this. Here's a crazy fact, straight from the coding guidelines. If more than one fetus is affected by a condition, every single affected fetus needs its own dedicated code. Right? So if fetus 2 and fetus 4 are both affected by something like a piperaceous fetus, you don't just lump them together with a catch-all code. No way. You must assign O31.00x2 and O31.00x4. You have to account for every single individual involved.
So we've got our blueprint built, but how do these theoretical rules actually hold up when you're looking at a real patient chart and the pressure is on? Well, before we put these rules to the test with our clinical case studies, I have a quick favor to ask. I love explaining the coding basics and guidelines, but if you really want more medical coding learning videos like this, please make sure to like and subscribe to my YouTube channel. It really helps me keep creating these deep dives for you guys.
Okay, let's put on our detective hats and dig into a chart. Section 4, Case Study, Second Trimester. Complicated monochorionic twin gestation.
Let's analyze this scenario together. A patient in her 24th week of pregnancy presents with monochorionic or monoamniotic twin gestation complicated by intertwin vascular communication. She undergoes elective reduction of the fetus because of intertwin vascular communication. One fetus had developed polyhydramnios. Man, there is a lot of clinical data packed into that short little paragraph. We've got the week, the chorionicity, the complication, the procedure, and the specific fetal condition. Take just a second and mentally prepare how you would sequence all of this.
Ready? Let's reveal the logic step by step because it brilliantly illustrates everything we just talked about. Step 1 is our principal diagnosis, O31.32x1. The 3 signifies elective reduction, the 2 puts us in the second trimester, and the 1 points right to fetus 1. Next, step 2, our additional diagnoses. We need to capture the specific issues for fetus 1, so we use O35.8xx1 for the fetal abnormality and O40.2xx1 for the polyhydramnios. And finally, step 3 brings in our gestation specifics. Remember that mandatory rule we talked about? Because we used a 7th character of 1, we absolutely must include the O30 code. So we add O30.012 for the monoamniotic/monochorionic twin pregnancy and Z3A.24 to capture the fact that it's exactly 24 weeks of gestation. See, it's a perfectly constructed coding narrative.
Section 5, Case Study, Full Term. Delivering a single live-born infant.
Okay, let's look at this final scenario. A patient with an initial twin pregnancy had previously undergone fetal reduction of one fetus due to suspected chromosomal anomalies. Fast forward to her 38th week of pregnancy, she is admitted and delivers a normal, single live-born infant. Guys, this is the exact riddle I asked you about at the beginning of the explainer. We're coding a single live birth, but the chart clearly started as a twin pregnancy. Let's see how we handle this one. Here's how we tell that whole story. Step 1. The principal diagnosis is O31.33x2, elective reduction, 3rd trimester, identifying fetus 2 as the reduced fetus. Step 2. We have to code the delivery outcome, which is Z37.0 for a single live birth. And then step 3 captures our gestation specifics, Z3A.38 for the 38 weeks, and crucially, O30.003 for the twin pregnancy in the 3rd trimester. Just look at how beautifully the O30.003 and the Z37.0 codes work together with our principal O31 code. They explicitly tell the next provider, hey, this was a twin pregnancy, a reduction occurred, and one healthy baby was ultimately delivered. I want to leave you all with this final thought today. A single delivery doesn't always mean a single gestation. Maternal history runs incredibly deep, and it has a profound impact on ongoing care. So as you look at these charts going forward, I want to challenge you to ask yourself, is your coding capturing the whole story? By mastering this O31.3 subcategory, you're making sure that no part of the patient's medical journey gets lost in translation. Thank you so much for joining me for this explainer. Keep up the fantastic work out there, and I'll catch you in the next one.